Hello friends, I am Dr. Vijay Prakash and today I'll be talking to you about centric relation. Now, centric relation is a horizontal jaw relation. Horizontal jaw relation means any jaw relation which has been recorded in the horizontal plane is the horizontal jaw relation. And horizontal jaw relation is of two types, that is centric relation and any position which is recorded other than centric relation are the eccentric positions or eccentric jaw relations. So we'll keep a focus on centric relation. Now centric relation is considered one of the most important spatial relationship of the mandible to the maxilla in the horizontal plane. So what do we mean by centric relation? According to the latest glossary of prosthodontic terms definition, it is defined as the maxillomandibular relationship in which the condyles articulate with the thinnest avascular portion of their respective disc with the complex in the anterior superior position against the slopes of the articular eminence. This is the articular eminence. This position is independent of tooth contact, and this position is clinically discernible when the mandible is directed superiorly and anteriorly. It is restricted to purely rotary movement about the transverse horizontal axis. So this is a long definition of centric relation, and it is quite interesting to note that in each of the glossary of prosthodontic terms from the beginning you have a different types of concepts for centric relation, and even the definition has changed over a period of time. So if we talk about the GPT first edition definition of centric relation, it says that centric relation is the posterior most or most retruded relation of the mandible to the maxilla when the condyles are in the most posterior unrestrained position in the glenoid fossa. So that is, it says that the condyles are in the posterior most position in the glenoid fossa. So if we see the concept, we need to check the anatomy and also the recent orthotomography studies which says no, it is wrong to say that the condyles are positioned in the posterior most relationship. So let us see, let us check the anatomy and find out ourselves what we want to see. So let us check briefly the anatomy of the temporomandibular joint. Although I am not going to go in detail about TMJ anatomy because it is a very wide topic to discuss on. So I will just confine what is required as of now. So this is the positioning of the condyle. As you can see, this is the articular eminence. This is the articular disc. This is the posterior band, and this is the anterior band. You have these ligaments. These are the fibers of lateral pterygoid muscles. This is the styloid process. So, and this is the glenoid fossa. So this is basically in brief the anatomy. Now if we see the normal functional movement of the TMJ, it is because of the opposition of the articular surface of the condyle and the articular eminence. So it is all the movements happen between the condyles and in between the articular eminence and the articular surface of the condyle. So basically what it is composed of, it is composed of these definable zone. In the center you have the thin central bearing area, and which is bounded by thicker anterior and these posterior bands. So these are the thicker anterior and posterior bands, and in the center you have the thin central bearing area. Now the central bearing area is densely composed of densely woven collagen fibers having no vascularity and no innervation. So because of this, since they are not having any vascularity or innervation, this is best suited to accept pressure. So this is basically a load bearing area. Now we can safely say that this region is the load bearing area, and since these are the posterior and the anterior band, they are thicker and they are highly vascular and they are highly innervated. So this is basically the load bearing area is this, not the posterior or the anterior region. Now, since the articular eminence is an inclined plane, can you appreciate this? This is an inclined plane. So the condyle disc assembly is stabilized on this slope by a muscular activity unless it is in a position of a biomechanical equilibrium. So the posterior movement of the condyle on the eminence has been attributed to wedging of the thickened posterior band of the disc between the distal surface of the condyle and the roof of the articular fossa. So this basically, the posterior band basically wedge between the condyle and the articular eminence, not allowing this condyle to move further backward. So you can appreciate here this posterior, thickened posterior band is not going to allow this condyle to move posterior to this. So it will be stopped by this. And how it will be stopped? It will be stopped by the innervated posterior band, possibly protects by the sensory feedback mechanism and thin roof of articular fossa from heavy pressure, and provides a biomechanically stable relationship by not allowing this condyle to move posterior, that is not allowing the condyle to move backwards in position. So this is the type of wedging which I am talking about. This is the posterior band which is getting wedged between the articular surface of the condyle and the slope of the articular eminence. Apart from the sensory feedback mechanism, another important and interesting thing is that how this condyle is positioned superior anteriorly, as we have seen in the latest definition. Now, that is because of the fibers of the temporomandibular ligaments. If you remember the initial figure which I showed of the anatomy of the TMJ, these are the ligaments, temporomandibular ligament fibers, which are oriented in appropriate direction, and they basically with the posterior force they will limit the movement of the mandible. So a posterior force will tend to pivot the condyle superior anteriorly, because of whenever there is a posterior force on these ligaments, it is going to pivot this this condyle in an superior anterior position because of the restriction exerted by the ligament. So this is another reason why the condyles are positioned superior anteriorly and not in the posterior most region. So that is how you have the superior anterior position of the condyles in the latest definition. This is through a lot of arthrotomography studies which have confirmed these all observations and findings. Apart from that, the fibers of the muscles of mastications, that is the elevator muscles, the depressor muscles, like the lateral pterygoid muscles, these all are oriented in such a way that the condyles, they lie against the anterior aspect of the posterior slopes of the articular eminence, and that is the reason this position is also called as the most musculoskeletally stable position, that is the centric relation. So what is the significance of centric relation? Why do we want to study centric relation, and why do we give so much of importance in recording of centric relation? And whenever we are doing a prosthesis, or even an orthodontist or a periodontist or a conservative dentist, any restorative dentistry, or in fact the basic treatment of dentistry, when we talk about why centric relation is that important. So let us see what is the significance of centric relation. One, it is a bone-to-bone relationship. This is very important. When we talk about centric relation is a bone-to-bone relationship. So it becomes normal. It is more repeatable position, it is a recordable position or a learnable position which remains constant throughout the life. It does not matter whether the patient is having teeth or whether the patient is not having teeth, this position, this musculoskeletally stable position is going to remain constant throughout the life. Thirdly, the patient can voluntarily and reflexively return to this position, and that is the reason why we put so much of importance in recording the centric relation. Fourthly, centric relation is a horizontal reference position in recording the maxillomandibular relationship and a starting point for developing any type of occlusion. So it is also called the point of return. This position is verifiable, and centric relation and centric occlusion, whenever we talk about rehabilitating or rehabilitating the edentulous patients, then always remember that the centric relation and centric occlusion should always coincide, because if they do not coincide, then the stability of the dentures will be compromised. The car should be mounted in centric relation because it is a point from which all movements can be stimulated in the articulator. Centric relation should be accurately recorded and transferred onto the articulator to permit proper adjustment of the condylar guidance. Edentulous patients use centric relation position for chewing and swallowing, and the muscles, bones, ligaments, teeth, all related structures grow into this muscle center. So that is the importance of centric relation, because as I just mentioned to you, that since it is the musculoskeletally stable position, that is the reason it is also known as the muscle center, because you have the balance of forces in this particular region, and that is the reason why this is a verifiable or a repeatable and a learnable position. Next is, how do we record centric relation position? Now we know the importance of centric relation position, but then now how do we record this position? It is very simple, because you have to record this position once you have done the vertical height adjustment, that is, you have recorded the vertical dimension, then you come and record the horizontal relationship, that is the centric relation. Now, centric relation, as I mentioned in the beginning, that it is a relationship of the maxilla and mandible in the horizontal plane. So what you need to do is you need to retrude the mandible in a particular position in the horizontal plane, so that the position comes to a centric relation position. Now, there are difficulties. It will not happen that you will be holding the jaw of the patient and the patient is going to come to the posterior position. So there are difficulties in retruding the mandible. And what are these difficulties? These difficulties can be biological causes, they can be physiological or psychological causes, and the mechanical causes. What are biological causes? Like lack of coordination between the groups of opposing muscles when the patient is requested to close in the retruded position. Or sometimes what will happen, say for example, the patient has lost posterior teeth. Now, when the patient has lost all his posterior teeth, then there is a natural tendency of the patient to protrude and then bite with the anterior teeth. So basically he comes in a class 3, pseudo class 3 relationship in which he is bringing the jaw forward. So you have to break this anagram and position the patient back to the centric position when you are recording this. So this is a type of biological difficulty in retruding the mandible. Second can be inability of the patient to follow the dentist's instructions. Could be a psychological or a physiological factors. It could be because of the stretch, relax exercises. You have to basically do these type of relaxation exercises, like tire the muscles of the patient, so that once the engrams are broken, then you can easily position the patient's jaw into the centric relation position. So these are the physiological causes. Mechanical causes could be your patient is fine, you are able to give proper instructions, but your record bases are not properly fitting or they are loose, then definitely you will not be able to record your centric relation position. Now, what are the methods? So these are the problems of retruding the mandible. What are the methods of retruding the mandible? One, always make the patient sit straight and relax the patient, making him or her feel comfortable. the patient is asked to bring his upper jaw forward. Now there is a tendency, because we know that the upper jaw is immobile, but if you ask the patient, okay, bring the upper jaw forward, then the patient will psychologically bring his lower jaw backwards, and that is what you want. And if you ask the patient the opposite, then what is going to happen? He will resist bringing the jaw backwards. So this is one reason. Second method is you ask the patient to take the tip of the tongue and touch the posterior aspect of the palate. So once he bring his tongues and touch the posterior aspect of the palate, he will automatically retrude the mandible, and then you can ask the patient to bite onto that. Thirdly, the patient should be instructed to touch, as I mentioned, to touch the posterior border of the upper record bases. The mandibular occlusal rim should be tapped gently with the finger. This will automatically make the patient to retrude the mandible. That is how you're giving a signal to the patient, okay, you have to retrude the mandible. So these are all the methods of retruding the mandibles. Now, once we have come to this position, next, what are the factors which will affect centric relation records? 1. Resiliency of the soft tissues. So one can be resiliency of the supporting tissues, resiliency of the supporting tissues, the accurate fit of the denture bases. So there should be an accurate fit of the denture bases. Thirdly, the TMJ and associated neuromuscular mechanism, the technique used to make records and accuracy of the recording devices, the skill and knowledge of the clinician, definitely what method you are using, what knowledge you are having in order to make a centric relation records, the cooperation and physical and mental well-being of the patient. Definitely the patient has to be cooperative, otherwise it is near to impossible to record a proper centric relation. Posture of the patient is very important. That is, the head should be straight and the patient should be gazing forward straight, and relax the patient. Size and form of the residual alveolar ridge, that is also going to make a difference. Quality and quantity of the saliva, should be normal saliva. Shape and size of the tongue, another important factor which is going to which can influence the centric relation record. The emotional stress of the patient, what emotional condition is that of the patient. Material and equipment used for making the records. Accuracy of the articulators. You have made a good record, but if the articulators in which you are transferring your records is not accurate, then definitely there is no point in making a good centric relation record. And the protective reflex action caused by faulty occlusal contacts. So definitely if the patient is having some natural teeth and some areas are edentulous, that is a partially edentulous patients, and if you are trying to make a record and you have a faulty occlusion, definitely your record will not be correct. So these are the factors which can influence the centric relation records. Now, what are the concepts of centric relation records? Essentially, there are two concepts of centric relation records. Now, what are those? So, what is the first concept? The first concept is the centric relation record should be made with the minimal closing pressure. Now, what do you mean by that? It means that you have to apply a minimal pressure so that the tissues supporting the base will not get displaced while the record is made. So as soon as the patient bites on the first contact, in that particular position you are going to flow the recording materials and you are going to record this position. So that is the first concept, that is the minimal closing pressure technique, and the objective behind this is to achieve a uniform contact of the teeth touching simultaneously at the very first contact, as I just mentioned to you. Now, what is the second concept? Second concept is a heavy closing pressure. That is, the centric relation records are made when you are applying a heavy closing pressure. That is, the tissues under the recording bases are displaced while the record is made. In one concept, we are not applying any force. With the first contact, you are going to flow the record and you are going to make the records. Second is a heavy pressure. That is, the concept is different. The tissues will be displaced as they are displaced on a heavy pressure, and in that heavy pressure you are going to make the records, the objective of this concept is to simulate the same displacement of the soft tissues as it would exist when the patient is going to apply heavy closing pressure. Now, if we see both these concepts, then we find that the most appropriate and the most commonly used technique is the first technique, which will give you the best results, because the patient will never be biting in a heavy pressure technique, except for certain instances, not always. But yes, the tissue should not be displaced, they should be minimally displaced, and that is the reason the first concept, as I told you, will be giving you a better result. Now, what are the methods of recording horizontal jaw relations? That is the classification of methods of recording centric relation. One, static method. Another one is the according to Boucher's, who has given classification for methods of recording centric relation. There are two types. You have static method and you have the functional method. Static method is that the mandible is located, and to assume the centric relation position, the rims are locked into this position, and you flow the recording material and you record in one particular position. That is the static position. Dynamic position is when the records are made when the mandible is in function. Like, for example, the patient is making the movement of the jaws, like smiling, puckering, making the lateral movements, and in that position you are going to make the record. So the drawback of this functional method is it causes lateral displacement and anterior-posterior displacement of the record basis. So that is the reason it is not that appropriate. Now, according to Gysi and Kingery classification, the methods of recording centric relation, they are of four types. You have the direct recording, direct interocclusal recording. Secondly, you have the graphic methods or Gothic Arch tracing. Thirdly, you have the functional methods, and fourthly, you have the cephalometric methods. Now, let us talk about them one by one. Apart from the Gysi and Kingery classification, you also have the patient-guided methods of recording centric relation and the operator-guided methods. Patient-guided methods are the Schuler technique, physiological technique, Gothic Arch tracing, myo-monitor technique, and operator-guided methods are chin point guidance method, three-finger chin point guidance method, bimanual manipulation method, anterior guidance with Lucia check, anterior guidance by leaf gauge, anterior the Gysi and Kingery classification, that is the direct interocclusal records. Now, the direct interocclusal record or the physiologic method, we also call this as a static recording method. Now, this was first given by Philip Pfaff in 1756, wherein he took a bite and he called that technique as taking a bite. This type of record was made with wax, or it can be made with impression compound, and you also call it as a mush bite or biscuit bite or squash bite. These are different names which have been given by different authors for this type of methods. Now, there are three types of physiological methods. One is the tactile or interocclusal check record method. Secondly, you have the pressureless method, and thirdly, you have the pressure method. So in a tactile or interocclusal check record method, basically the normal functioning of the patient, proprioception and tactile sense is important in order to make an accurate record. And in this, you are asking the patient to retrude the mandible, or you can follow a number of methods which I had already explained in just some times back about how to retrude the mandible. And then you can make a record. So that gives you basically the tentative jaw relation. So tentative jaw relation, how do you get? Very simple words. You have the maxillary rim, you insert the maxillary rim in the patient's mouth, you do a phase transfer. Maxillary cast is mounted on the articulator, vertical dimension at rest is established, and then the mandibular rims are reduced. And you do a vertical dimension, you basically check the vertical dimension, you leave you have the interocclusal space, and once you have done the jaw relation, you position the patient's mandible into a centric position and then take a bite. So that is basically a tentative jaw relation. This you need to verify when you are making different records. That's how we do in complete denture patients. Now in this, when you are taking this bite, you can use either a pressureless method or a pressure method. Now pressureless method, the most commonly which we use is the nick and notch method. Now in this nick and notch method, you make a V-shaped notch on the maxillary occlusal rim, and a nick is made anterior to this. This is a nick and this is a notch which is there. So a trough is created on the mandibular rim from the premolar region. This is on the mandibular rim. You create a tuft like this, and to the distal most region, from the premolar region to the distal most region, petroleum jelly is applied in the nick and notch areas. You can use aloe wax or zinc oxide paste, impression paste is placed in the trough in the mandibular rim, and the patient is guided into a centric position. And once you have asked the patient to close into a centric position, allow this material to set. The occlusal rims along with the recording materials are removed together. Never attempt to separate that, because then you can break the record, and you have to repeat the procedure. So any excess material is trimmed and the cast are mounted on the articulator using this method. So this is a pressureless method. Some authors have also tried to use a staple pin method or a swallowing method. Staple pin method is just using a stapler pins. Once we have made the patient come into a centric position, use a stapler pins, but I don't recommend this because you are applying a lateral force on the mandible, and that can change the record of the patient. So another method is the swallowing method. Now swallowing method was advocated by Shanahan in 1955. So in this method he used the soft cones of wax in the lower mandibular area, and in the upper, once he has adjusted the upper rims, then he has asked the patient to repeatedly swallow, and with the swallowing of this wax would reduce and come to a particular position in which once there is no change, then you seal that into position and then you remove it. So this is also another method in which you are using swallowing as the method of recording centric relation. Another method which can be used. Next is the pressure method. Now this was advocated by Green, in which he called this technique as used this as a pressometer to check equalization of pressure in recording the centric relation. It consisted of two celluloid strips when he placed on both the sides of the occlusal rims. Once you have achieved the centric relation position, and then he asked the patient to bite. If the pressure was unequal, he would adjust that so that till the time the pressures are equal, and then he will seal it into that position. That was the pressure method. Next is the graphic method of recording centric relation. A very important discussion for this. I will try to keep and make this discussion small, because this can take a very long time in discussing this topic, but I will just tell you in brief. Graphic methods of recording centric relation, by definition, what is Gothic arch tracing? You can also call it as Gothic arch tracing, and Gothic arch tracing is defined as the pattern which is obtained on the horizontal plate. You can appreciate this is the pattern which is obtained on the horizontal plate used with the central bearing tracing device. So this is the definition of Gothic arch tracing, and you have different types of tracers which are used for making this record. First, needle point tracing was done by Hesse in 1897. It was advocated and improved and popularized by Alfred Gysi in 1910. Apart from Gysi, Sears used it, Hanau used it, and you have different authors which have used it over a period of time. Phillips gave the central bearing point, which was based on the concept that the device will produce equalization of pressure on the supporting tissues. You had Phillips tracers, which will indicate the path of condyle and direction of position of the mandible. Then you have the intraoral tracing devices, which was introduced by Ballard, Steedle, and Measurements. So there were different authors which advocated graphic records for recording the centric relations. Now, essentially, there are two types of tracers. One is the extraoral tracer, another one is the intraoral tracers. Now, what are extraoral tracers? Extraoral tracers, as the name suggests, is placed outside the oral cavity. It is visible. So the figure which you see in front of you is the intraoral tracers, which is placed outside. This is the occlusal rim. These are the plate. This is the tracer, and this is the bearing pin. On the lower, you have again, this is the plate, and this is the tracer, and you have the recording plate here. So it is placed outside the oral cavity. It is visible. Tracings are large. You can definitely see that. Apex is more discernible. You can make out what is the apex. This is very important because this apex gives you the centric relation. No hole is required when you are taking the whenever you are viewing the extraoral tracers. Patient is guided and directed more easily. The patient is able to control the device more easily in comparison to the intraoral tracers. Tracings made away from the centric of rotation. Example for this is extraoral tracers. You have the Gysi tracers, the height tracers, and Stansberry tracers. So this one, the figure which you see in front of you is the height tracers. Now, apart from this, you have the intraoral tracers. Now, what are the intraoral tracers? Now, intraoral tracers, as the name suggests, is placed inside the patient's oral cavity. It is not visible. You cannot see that. Tracings are smaller, difficult to locate the true apex. Tracer should seat in the hole for accuracy. If it does not seat into the hole, your accuracy for your record is not there. It is difficult to locate the true apex. Tracer should seat in the hole, as I told you. Difficulty to guide and direct the patient because you don't know whether once you ask the patient to open, once you have removed the rim, then only you will come to know whether the record is accepted or it is not accepted. So tracings are made closer to the center of rotation. Definitely the patient has more control with these, not talking about the comfort but control, because it is closer to the center of rotation. That is the reason it is closer to the center of rotation. In case of intraoral tracers, examples are Steedle, Ballard, and Measurement tracers. So these are examples of intraoral tracers. Now, what are the factors which we consider during graphic methods? One is the stability of these record bases, because if the record bases are not stable, you will never be able to make a proper centric relation record. The occlusal rims should offer more resistance to the horizontal movements than the central bearing point. There should be no resistance in the movement of central bearing point. They should be away from that. Difficulty to locate the center of arches in excessively protruded or protrusive jaw relations. It is difficulty to record centric relation in a class 3 or a highly class 2 relationship using this method, that is the graphic method. Tracings with only sharp apex is considered acceptable. Double tracings or any deviation, rounding of the tracings is discarded, and you have to make a new record. So graphic methods can record the eccentric relationship of the mandible to the maxilla, that is the protrusive and the lateral records, and the centric relation record. Very briefly about the procedure of Gothic arch tracing. Vertical dimension of occlusion is predetermined, that is you have already taken a tentative jaw relation. Tracing devices are attached to the occlusal rims, as you can see in the patient's mouth, and the rims are placed in the mouth. The patient is instructed to open and close the mouth number of times, and you ask the patient to make these movements before doing the recording. So that is, you ask the patient to bring the jaw to the most posterior region, ask the patient to bring the jaw forward on biting, and then open and come back to the original position, and then move the patient to right and left position. So the patient is first instructed to make these maximum anterior-posterior movement of the mandible to establish the protrusive range, because once the patient brings the jaw forward, he is giving you the protrusive range, and then you ask the patient to again open and bring back his mandible, and in the centric relation position again ask the patient from there to move the jaw towards the right, open, come back to the original position, then take the jaw towards the left, again open and bring back to the original position. So this is known as the Ney's mandibular excursion guide, which you can follow in making these movements, and with this you get the proper record. This is the Gothic arch on the horizontal plane. You can use soot, the black soot, or maybe an ink which does not interfere in the movement of the central bearing point when you are making the record. So what is the importance of Gothic arch? Now, needle point tracing is basically a single representation of the position of the mandible and its position in the horizontal plane, which you can see here. Dull or rounded apex of the needle point tracing is not indicative of an exact centric relation. If it is, it has to always be a very sharp, this angle has to be very sharp, so then only it is acceptable as the proper centric relation position. If it is the dull or rounded, you will discard this and make a new one. So what are the drawbacks of needle point tracings? It is relatively time consuming. You spend a lot of time in recording the graphic tracings. It requires well balanced, non-displaceable upper and lower alveolar ridges to allow stable and retentive acrylic bases. Large tongues can cause interference in the base during the recording. True excursive movements are difficult for the patient to repeat, and too much of cooperation from the patient is required. Too much of training is required on the part of the patient, and you also have to keep patience. This is very important. So tracing restricts the available tongue space, which can produce recording errors, because you are blocking the space of the tongue that may interfere with your proper records. Next method is the functional method. Functional methods are the functional chewing records, which is defined as the record of the movement of the mandible made on the occluding surfaces of the opposing occlusal rims by teeth, or you can have scribing struts, and they are produced by simulated chewing movements. So there are two types of functional chewing methods. We have the Patterson method and the needle house method. Now, what is the Patterson method? Patterson method, he devised this, he used a wax occlusal rims, which was given by M.F. Patterson in 1923. A trough was made in the mandibular rim and was, as you can see, a trough was made in the mandibular rim, and it was filled with the mixture of plaster and carbonundum paste in a 1:1 ratio, and the patient was asked to move his or her mandible and continue this motion until a curvature is formed on the rim, that is with this trough. So that is the functional method of recording the centric relation. So this was done in order to equalize pressure and provide uniform contact in all excursive movements, and the movements of the mandible generated compensating curves in the plaster and carbonundum the material, and when the paste is reduced to a predetermined vertical dimension of occlusion, the patient is instructed to retrude the mandible in the position, and this retruded position determine the horizontal jaw relationship, and both the rims are joined with the means of staple pins or accordingly with the recording material. So this is the Patterson method, which was described by Patterson in 1923. So next is the needle house method. It is more commonly used functional method in comparison to Patterson method. In this method, the occlusal rims are made up of impression compound, and you have 4 triangular shaped studs with cutting edges like this, which is inserted into these the maxillary rim in the premolar and molar region. The rims are inserted into the patient's mouth, and the patient is instructed to make mandibular functional movements. So during making of these functional movements, the studs are going to engrave 4 separate Gothic arch. You can appreciate this. they are going to engrave 4 separate Gothic arch recordings into the blocks of a compound, and these tracings relate to the movements of 3 planes and are called as the chewing records. And that is the reason why we call this as a functional chewing record. And these records are placed on an appropriate articulator, and the condyle elements are adjusted accordingly. And then once the articulator is programmed, and then you can go ahead with your further treatment. Another method, which according to Gysi and Kingery classification, was cephalometric recordings. Although it was advocated by Piot and Schaefer in 1952, but according to them, you use a proper centric relation and vertical dimension of occlusion were determined on the basis of cephalometric radiographs. But this method is, however, very impractical and has never gained any kind of popularity in recording, because what you record in the patient's mouth is different, and what you see on the cephalometric radiographic evaluation, that is different. So definitely we don't use cephalometric recordings to do recordings for centric relation. So these are all the methods of recording centric relation. Although centric relation is a very, very wide topic, we can go on for a number of hours to discuss this particular topic, but I have confined myself in a very brief aspect. So with this, we come to an end of a topic. Thank you for watching the video.